Thanks again for joining us. So this is part of the continued professional development program that we put on through the NIHR-funded DaRe2THINK trial. Many of you will have come and seen us before, but we're great to see you if you're existing but also new. Minnie at the end of the program will just give you a bit of an update around how we're going with DaRe2THINK and how you can get further involved. But for now, I'd really like to welcome our keynote speaker today, who's Clare Taylor. So Clare has been championing primary care and research in primary care for a long time, has been awarded an MBE and RCGP medals for her work. Really great that she's now a professor of general practice here at the University of Birmingham and will be giving us a talk today on the NICE heart failure updates. So thanks, Clare, for joining us. I'm really keen to hear what's been going on and how that will impact on heart health in primary care. Thanks a lot.
Thanks very much, Deepak and the team, and thanks for the invitation to come back. I presented on heart failure diagnosed about 18 months ago, so it's great to be able to share the update from NICE on heart failure treatment. So can everybody see my screen okay for my presentation? Yep, great. So I was the one of the 3 GPs on the NICE chronic heart failure guideline update committee, and we spent 18 months reviewing the evidence, particularly around the treatment for chronic heart failure. And I'd like to spend the next 15 to 20 minutes just telling you exactly what we recommended, just as a summary for busy practicing GPs. There we go. So primary care is really central to the heart failure pathway, both in terms of diagnosis and treatment, as we all know. So patients present first to primary care with symptoms of heart failure, particularly breathlessness, ankle swelling, exhaustion. And as GPs, we can request a natriuretic peptide test. And if that test is raised, then we can refer for echocardiography and specialist assessment. And at that point, the diagnosis is made usually by a specialist and treatments are initiated. And then the patient comes back to us in primary care, often for ongoing management. But if the patient deteriorates again, we might send them back to secondary care. So primary care really is crucial to the patient pathway. So as I mentioned, NICE update was largely around treatment options. The diagnostic recommendations remain the same. So this is the algorithm from 2018, which gives thresholds for natriuretic peptide testing. So if the NT-proBNP blood test is less than 400 in somebody who's presented with a suspicion of heart failure, so symptomatic, we can think heart failure is unlikely and to consider other diagnoses. But if it's above 400, that patient does need a specialist assessment and echocardiography. And if it's below 2000, the recommendation is 6 weeks. And if it's 2000 or above, then it's 2 weeks, just because these patients are highly likely to be hospitalized and have poor outcomes in terms of survival. So we need to get them diagnosed and treated sooner. But what I'd like to talk about today is really what's changed in the heart failure guideline. And for me, having been on every committee meeting for the last 18 months, there's really 5 key areas that I'd like to talk to you about. Team working, the recognition of 3 heart failure subtypes, this concept of 4-pillar treatment, heart failure with preserved ejection fraction treatment specifically, and IV iron. And I'll talk about that for a few minutes, and then also how we actually implement this within primary care. So firstly, team working. So as part of the NICE 2018 recommendations, the multidisciplinary team was one of the recommendations within the guideline. But in 2025, the pharmacists have been specifically named and added to that recommendation. And I think that's really recognising the crucial role that pharmacists play within heart failure treatment and the role of specialist pharmacists within the MDT. The second change was around heart failure subtype. So heart failure by definition is in patients who are symptomatic. So the echo alone being abnormal doesn't mean that the patient has a diagnosis of heart failure, and that's quite a common misunderstanding. But in 2018, the recognition of heart failure subtype was heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. And then there were these people in the middle that had an ejection fraction that was mid-range or mildly reduced. So I think the European guidance has recognised the 3 subtypes for a few years now, and NICE has brought the UK in line with that, in recognising that heart failure with reduced ejection fraction is patient symptomatic and their echo shows an ejection fraction of 40% or below. This mid-range or mildly reduced ejection fraction, so heart failure and an ejection fraction of 41 to 49%. And then this third category, heart failure with preserved ejection fraction, so patients are symptomatic but their ejection fraction is 50% or more, but there are other abnormalities seen on the echo, particularly an enlarged atrium, left ventricular hypertrophy, raised pulmonary artery pressures. So this is that the heart is pumping out a normal amount of blood with every heartbeat, but there's a failure of relaxation during diastole because of a stiffening and fibrosis of the heart muscle. And these definitions are really important because it guides the type of treatment that patients should be offered. So the reason for the update, we spent 2.5 years up to 2018 updating the guidance, and then there was a call for an update needed only a few years later because of the SGLT2 inhibitor trials. So SGLT2 inhibitors, so dapagliflozin and empagliflozin, are drugs that we commonly use in primary care in patients with type 2 diabetes. But trialists recognised that in the type 2 diabetes trials, heart failure outcomes were better. So these trials were done in patients with and without type 2 diabetes who had heart failure. And there was a normal amount of treatment, so ACE inhibitors, beta blockers, MRAs, but the trials looked at whether or not the addition of an SGLT2 inhibitor or placebo improve patient outcomes in terms of quality of life, reducing hospitalizations and improving survival. So the first trial to report was DAPA-HF, so dapagliflozin in patients with heart failure with a reduced ejection fraction, significantly reduced hospitalizations and mortality, and really quite early. And then the trial using empagliflozin in HFrEF showed exactly the same. So this was really strong evidence that these drugs significantly improve patient outcomes. So then came the trials in heart failure with preserved ejection fraction, which also included this mid-range group with heart failure with mildly reduced ejection fraction. First came empagliflozin trial in Emperor Preserved, and then came DAPA with DELIVER-HF. These trials didn't show a mortality benefit in these patients. They were generally older, more complex patients with multiple long-term conditions. But what it did show is an improvement in outcomes, both in terms of quality of life and reduced hospitalizations. So there was also a benefit in using SGLT2 inhibitors in these patients as well. And that's different to the other trials like ACE inhibitors, beta blockers, where there hasn't been the benefit shown for those drugs in patients with HFmrEF or HFpEF. So this led us to convene as a guideline group and come up with these recommendations based on all the evidence. And what we describe as the 4 pillars is a term that's been commonly used for patients with HFrEF. And so the NICE guideline is OFFER, which is their strongest recommendation, because there's really clear evidence that patients being on an ACE inhibitor, a beta blocker, an MRA, so spironolactone or eplerenone, and an SGLT2 improves patient outcomes. And then the second recommendation here is something that was already in the 2018 guideline and strengthened in 2025, is that for patients on maximum tolerated doses of all 4 of these medications, we can consider a switch of the ACE to an angiotensin receptor blocker, neprilysin inhibitor. So that's the sacubitril valsartan. So there is that recommendation as well if patients remain symptomatic when they're on the 4 pillars. So next, in the heart failure with mildly reduced ejection fraction, the recommendation is a consider rather than an offer recommendation. And this is largely around the strength of the evidence. There wasn't a survival benefit in the SGLT2 inhibitor trials, but there was certainly great improvements in quality of life and reduced hospitalisation. So consider again the 4 pillars, so ACE inhibitor, beta blocker, MRA and SGLT2 in patients with this mildly reduced ejection fraction as well. And the guideline sort of signpost towards the TAs, which are the technology appraisals which come out when drugs have just been trialled and there's a positive result. So the guideline has to align with the technology appraisals that were done for those drugs at the time. And then thirdly, heart failure with preserved ejection fraction. So again, we now have treatments for this type of heart failure. In 2018, the recommendations were really limited for this heart failure subtype because there wasn't any clear scientific evidence of prognostically beneficial treatments for patients with HFpEF. But when we looked back at the evidence, we found that there was significant improvements in outcomes for patients with HFpEF in terms of MRA treatment, so Spiro or Pleuronone, and also the SGLT2 trials that had recently reported also show these benefits and outcomes in terms of quality of life and reduced hospitalisation. So for the first time in NICE 2025, we do have recommended treatments for patients with HFpEF in terms of MRA and SGLT2 inhibitors, which is really exciting, and it really supports the need to diagnose this type of heart failure. And then the final thing in the key updates from the heart failure guideline is around intravenous iron. So this is just in patients with heart failure with reduced ejection fraction because that's where the evidence is at the moment. There is a research recommendation saying we do need to look at this intervention in HFmrEF and HFpEF. But in these patients with HFrEF, the trial showed that there is an improvement in outcomes if we treat with intravenous iron in certain circumstances. So there is a role for all of us in the MDT, including those of us in primary care, to assess the iron status for patients to see if they're eligible. And these are the tests that we need to do. So a TSAT, a ferritin and a hemoglobin, so a full blood count. And so who is eligible? So if on the ICE drop-down list you click the iron studies, you'll get a TSAT, you'll get an iron, and you'll get a total iron binding capacity, which is how TSAT is calculated. So if a patient has a hemoglobin of 150 or less, then that's when they're eligible. So they don't need to be anemic to be eligible for intravenous iron. It's to do with the iron deficiency that is the most important thing that was tested in the trial. So a TSAT of less than 20% or a ferritin of less than 100 makes them eligible for intravenous iron. And we added in this recommendation just as a safety net, really, just as a reminder for people reading the guideline that if we detect iron deficiency anemia in this circumstance, don't assume it's related to the heart failure and think about investigating for alternative causes. So hopefully that's a whistle-stop tour of the 5 key recommendations that have sort of changed things in the NICE 2025 update, and I will just summarise those again at the end. But what I wanted to do next was just present some of the recommendations around how we do this as a multidisciplinary team, and that's particularly relevant in primary care. So on the guideline committee, we discussed the issue of 4 pillars, and these patients who are living in the community with heart failure, the median age of diagnosis is 76. They usually have 3 or more other long-term conditions. So this recommendation is really around looking, as we always do as GPs and primary care teams, looking at the patient's history, what else is going on, their frailty status, and discussing with the patient when deciding what we do next in terms of heart failure management. And this will hopefully guide which medicines we choose, the order and the timing of the introduction of each of these medicines, and the initial doses that we start and how quickly we go up on those dose increments to achieve an optimal dose. So this is particularly important when we're initiating the 4 pillars in patients with HFrEF or HFmrEF, because what we don't recommend for the 4 pillars is to start all 4 on the same day in the same consultation. And that sounds obvious, but it's important to sort of emphasize that we need to start things gradually, up titrate gradually in the context of that patient. If we have got a fit and well patient in front of us with a good renal function, a good blood pressure, we can do this fairly rapidly. And there is evidence from the Strong HF trial that actually we need to get these patients on all 4 pillars as quickly as possible to improve outcomes. So we do want this to happen as quickly as possible, but not to the detriment of the patient in terms of falling over due to hypotension or an acute kidney injury. This recommendation was discussed a lot, and this is around who initiates ARNIs. So patients who we're thinking are eligible for sacubitril valsartan if they're still symptomatic despite being on the 4 pillars. The recommendation is to consider seeking advice from a heart failure specialist. There will be some people in primary care that feel happy to initiate this, perhaps GPs with a special interest, but this is the recommendation. There was also a similar recommendation around SGLT2s in the draft guideline, but following consultation and also discussion on the committee, we took that out because we felt that primary care teams were very used to prescribing SGLT2 inhibitors already because of their experience in diabetes. So for ACEs, ARBs, ARNIs and MRAs, we should have a renal function before we start any treatment. And then the recommendation is that we check the renal function again 1 to 2 weeks after starting treatment, but also after each dose increment, and then at 3 to 6 monthly intervals as required. But also if a patient becomes acutely unwell for some reason, we would want to check the renal function again in the case where it may be compromised. So these are a sort of safety recommendations. So if we start in 4 pillars, there is a risk of hyperkalemia or a dip in renal function. So this is what we agreed in terms of a 50% reduction or a potassium above 5.5, follow local guidelines. There are potassium binders which have been assessed through NICE technology appraisals, which can be used and are increasingly being used by heart failure specialist teams to address the issue of the potassium being up too high when you're trying to get patients on all these treatments to optimise their care. We also said the blood pressure is obviously important and needs to be measured before and after each dose increment, and we signpost towards the hypertension guidelines for management of blood pressure, including postural hypotension. There's also a few recommendations around beta blockers. Some of these haven't changed since 2010, but there was discussion on the committee around assessing heart rhythm and heart rate. So there are 2 new recommendations around doing an ECG in patients before prescribing a beta blocker or where they have a symptomatic bradycardia. Now, these patients should already have had an ECG prior to diagnosis because that's in the diagnostic algorithm that NICE recommend at the point of diagnosis. So as well as doing an NT-proBNP test, we should also do bloods, an ECG and a chest x-ray just to make sure we're not missing anything else. And then there's recommendations for people with CKD. So CKD and heart failure commonly exist alongside each other. And these are fairly sensible recommendations. Consider a lower starting dose or lower dose increments in people with a GFR less than 45 and involve the renal specialist if it's below 30. And finally, don't forget the basics. So the recommendation on diuretics has been in the guidelines since the first one was written in 2003. We know that loop diuretics can very effectively relieve congestive symptoms and fluid retention in patients with heart failure. And these can be used while we're waiting for that echo and that specialist assessment. We can offload patients in the community, monitoring their renal function while we do so to make them feel better. But once that fluid is offloaded, it's important to titrate down again so that patients are on the lowest dose that's required, because then that allows more blood pressure and renal function to optimize these 4 pillars in the case of HFrEF, to give that prognostic benefit that we saw in the trials, and all the other things that we would normally do, vaccinations, checking for AF, blood pressure, cholesterol, diabetes. So we have 2 very clear downloadable PDFs, one for heart failure with reduced ejection fraction and one for heart failure with mildly reduced and preserved ejection fraction. And that summarises everything that I've said over the last 15 minutes. So there's things you could download the PDF onto your desktop, so you've got it there if you have a patient coming into the surgery with heart failure, and you can quickly reference what to do. So they're both available on the NICE website to excuse me, to download. And then just a final plug. So I'm the research lead for the Primary Care Cardiovascular Society. We recently recorded a podcast on the NICE chronic heart failure guideline update. We also have an academy which has webinars and online materials. It's free to join. And you can listen to the podcasts or go onto the academy free of charge at any time. And that's a good way to keep up to date with cardiovascular things more generally. So thanks for listening. I hope that was a good overview of what's changed in the new NICE guideline. Welcome any questions now, and you can also contact me directly at Birmingham. So thank you.
Thank you, Claire. That was amazing. I have 1,000 questions, but there's lots in the chat as well, so we'll go with those. We've got a few minutes, and then we'll switch over to Minnie. So there's so Rubina's got a question about whether you think there's any qualifications required for specialist heart failure pharmacists. She says completes reviews and joins MDTs, but no formal qualifications. Does that kind of fit into the NICE approval of who should be authorising these sorts of meds?
Yeah, I think so. NICE don't generally recommend specific training required for any member of the MDT. And I think it's that competency based. So if you feel competent to be able to do this work, pharmacists have such a crucial role to play. And I think the role is changing. So at Birmingham, the pharmacists coming out of our courses this year are going to all be prescribers, so they can do the prescribing as well as advising. So I think it's a real time of transition, and pharmacists are really key now. And it's great that they're named in the NICE guideline. And I think it will vary locally how this is actually adopted.
Yep. Absolutely. So the next question from Kaloni was that patient's blood pressure is 115/70. They're already on ramipril 5. Would it be safer to increase the dose to maximally tolerated, conscious regarding low blood pressure? I think this comes back to one point you made, Claire, which is it's much more important to have multiple drugs than it is to have top doses. And we see this a lot across the whole cardiovascular spectrum, is that people try to target kind of higher dosage, where actually you get most of the benefit from these drugs on the mid doses. So in that case, I mean, my suggestion would be you leave them on 5 of ramipril, and where you can get in something else like an SGLT2. Is that what you would agree from NICE?
Yeah, absolutely. And these 4 pillars, we are trying to get people on all 4 pillars. And it partly depends on the circumstance of the patient. So if you've got somebody who's quite tachycardic, you might go in with a beta blocker next to get their heart rate down at the same time. SGLT2 inhibitors are just so easy to use, though, you know, a single once a day dose. Yep. So absolutely. Yeah, very much so. Get people on as many as possible, not necessarily the top dose, as you say, Deepak.
Yep. There are some questions which, in view of time, I'm going to skip, as in the challenging parts of the NHS. We know the targets and stuff are really hard to meet. There's one, if we could answer a quick answer to that, Claire, because I know this is your area of real interest. But there was a question about recommendation for serial or annual BNP measurements whilst on treatment.
Yeah, so there is no recommendation in NICE for that, other than people in a very small subgroup who are, I think, below 75, recently hospitalised and have a really good renal function. So in the 2018, we looked at all the evidence for this, and actually there wasn't evidence that it improved outcomes. Now, since then, there is the STRONG HF trial, which used MP guided treatment titration, and there are some centres using that STRONG HF protocol, We did review that as part of NICE, but it didn't then lead to a recommendation because the trial used people that were younger, fitter than the average population we see in the NHS. And also the trial was done in multiple countries, so there weren't many sites in the UK. But it's certainly a recommendation that you can consider sort of using the strong type protocol, but there's no specific recommendation on MP testing in treatment. So the role is really just in diagnosis at the moment for NICE.
Great. Thank you, Claire. And thanks so much for your time today. There are a few more questions in the chat. If you do have some time, maybe you can have a look and reply. But I'll move over to Minnie just to give you an update in the last few minutes on DaRe2THINK and where everyone on the call can get involved. Thanks, Minnie.
So yeah, an update for the DaRe2THINK trial, as some of you may have been aware, and because you're already taking part in DaRe2THINK, is that the DaRe2THINK trial is a clinical trial which is funded by National Institute for Health and Social Care Research and sponsored by University of Birmingham, and we work in collaboration with Clinical Practice Research Data Link under MHRA. So the DaRe2THINK trial is looking at integrating clinical research into usual NHS care by looking into the routinely collected NHS primary care data. This is to reduce the burden on both NHS staff and patients who are taking part in the DaRe2THINK trial. So the DaRe2THINK trial is an exemplar of this new delivery method and targets a key public health issue of how to prevent cognitive decline and dementia on patients with heart rhythm disorder. So the trial is able to screen over 13 million patients to identify potentially eligible patients. And now we have recruited 490 practices who are actively recruiting patients. And we have recruited a total of 1,192 patients. So the trial is getting a very good uptake of 5 patients invited. For every 5 patients invited, 1 patient is randomized. So we are continually improving the platform on DaRe2THINK. So for those practices who have not yet or who need any assistance, practices who have already on DaRe2THINK and who need assistance, you can book a meeting using the QR code. And for those practices who are interested to take part in DaRe2THINK, you can click the right QR code for new practices, and we can have a short introduction meeting for 15 minutes to give you and discuss with you what the trial entails.
Great. Thank you, Minnie.
Thank you.
So thanks all for your time today. There is a form I think Abby's just put on if you want to fill that in for some suggestions on how we can make this better. Thanks again for all your time today. Yeah, just to mention, we've done a huge amount of work in the background to improve DaRe2THINK and how we can access records and how it can make your lives easier. So do have a look at the new platform that's been created for DaRe2THINK. And as Minnie mentioned, if you are an existing practice, we've completely updated all of those legacy systems, which were a bit clunky. It's now a very quick and efficient review process. So we've taken on all board your comments and suggestions over the last couple of years. And so it's a really great delivery method now for doing large-scale primary care clinical trials. So thank you all for your help, and hopefully see you at the next meeting. Bye-bye.